I've constantly had ultrasounds, and right up until I had the hysterectomy they never showed anything.
But I had a lot of ultrasounds and scans which showed up nothing.
I only had an internal ultrasound performed last Wednesday, and for that to happen caused me agonising pain afterwards.
I've had lots of ultrasounds. I've had an internal one to try and detect the endo, but it's the freckle one which you can't detect. You could only tell by like putting pressure on a particular point, and he did it from lots of different angles and it was painful.
I noticed on the pelvic ultrasounds that I had a few massive cysts on my ovaries. One of my ovaries was 4 times larger than what it was meant to be.
And my physio actually has used the ultrasound probe, and that sometimes helps in reducing like inflammation.
The advantage of having an ultrasound or an MRI is that you're not having to go through unnecessary surgery.
Our job today is to explain the role of medical imaging in the investigation of pelvic pain and endometriosis, and we hope to guide you through the role of ultrasound and MRI and look at how these imaging modalities can work independently, but also we would see how they work really as complementary tools as part of a multidisciplinary team approach. So there are 176 million women aged 15 to 49 worldwide living with endometriosis, and so there is a real need for imaging and the investigation of pelvic pain to be done well. Natalie and I are often seeing women who have got a long history of pelvic pain, infertility, and often have had multiple surgical procedures. So when we were reviewing the intro that we were provided with today, and I think from hearing Sue Evans speak, the intro is spot on. Women come in for imaging and they often make comments such as that they thought that ultrasound could not see endometriosis, or that they've had lots of scans in the past that weren't helpful, or they completely misdiagnosed how severe the endometriosis was. The last 5 years has seen a significant change in the approach to endometriosis in terms of imaging, both in terms of how we guide and plan management. And that's been a combination of research that's been done mostly in Brazil, but also a real improvement in the resolution of machines and better understanding. And I would say that it's very important that you understand your pelvis and you understand what the imaging means, and then you can make sure that the treatment options offered to you are centred around the outcomes that are important to you, whether that be pelvic pain or fertility concerns. Ultrasound can either be performed transabdominally, so through your tummy, or transvaginally. And the quality or resolution of ultrasound imaging relates to how close the ultrasound probe is to the structure it's looking at. And that's why the majority of gynaecology imaging is done transvaginally. So this is a transvaginal image and this is a transabdominal image through a full bladder. And the different approaches are going to be different for different women, and it's important that prior to an exam someone obviously goes through that with you and discusses the pros and cons of the two approaches. In some women, a transvaginal approach is not appropriate or is too difficult to manage from a pain point of view. But a lot of information can be obtained from a baseline transabdominal scan if it hasn't been done in the past, particularly in adolescents or young women, to exclude many causes of pain. So we can obviously see the uterus well, look at the lining of the uterus and assess the ovaries, and we can also assess well the response to the hormonal medication that someone may be on. A transvaginal exam's main advantages is it allows more detailed assessment of pain, allows assessment of the pouch, which is that space between the uterus and the bowel, allows us to see the rectum, and allows a more detailed approach in terms of assessment of deep endometriosis, which is important for surgery. So a routine scan will assess the uterus, the tubes, ovaries. This box here is showing us the support ligaments of the uterus, or the uterosacrals, the bladder, the cervix, the vaginal wall and the rectum. And I think whether your management plan is centred around pain management or fertility concerns, it's important to have this baseline assessment of the uterus and the ovaries. It's important to exclude other pathology that can influence your management, whether that's other kinds of ovarian cysts, fibroids of the uterus, or in some cases an unusual shape to someone's uterus. And because endometriosis, as we've seen in the surgical pictures, commonly affects these main support ligaments, we now know how to assess those in ultrasound, which in the past has not been well done. So I think a good ultrasound can certainly provide important information to understand the type and the extent of the endometriosis, certainly in terms of surgical planning. One of ultrasound's main advantages is that it's dynamic, so it's done in real time, so we are able to localise pain, we're able to provide information about the mobility of structures and the degree of adhesive tissue in the pelvis. And as from the videos we've seen, that adhesive tissue can give people quite significant symptoms and can often be very difficult to manage surgically, so it's important to know about. The gynaecological organs, as opposed to anything else, have a different normal appearance depending on where someone is in the cycle and their age. It also has a different appearance depending on what various hormonal management they be on, whether that's the OCP, Implanon, Depo, and that can really affect the appearance, and that should be factored into any ultrasound report.
Now we're just going to shift to MRI, or magnetic resonance imaging. And the first question to answer is, what is an MRI? So an MRI is an imaging technique that utilises a magnetic field and radio waves. And what it does is it uses that information to create detailed images of the organs and tissues within your body. As you can see from the photo, the MRI is a large tunnel-shaped machine that you lie inside of. And what happens when you have an MRI is that the high magnetic field that you lie in temporarily realigns all the hydrogen atoms in your body, and then the radio waves cause these aligned atoms to produce a very faint signal which is detected by the machine. This information is then processed by complex algorithms and computers to create the image that I, as a radiologist, will read. So here we have an image taken, if you can imagine, being cut down the middle and looking from the side, and you can see the bladder, the uterus, the cervix, and the rectum. This, of course, raises the question of whether MRI is safe, and provided that there are no contraindications to MRI, which I'll touch on later, it is a very safe modality. We've been using it for over 40 years without ill effect. And the nice thing about it, like ultrasound, is that it doesn't use ionising radiation to obtaining imaging. How do we perform the MRI? Well, it takes about half an hour to 45 minutes. And when we do a pelvic MRI, what we do is we put a special coil, which is this white device that you can see over the top of the belly. So we focus it down on the pelvic region and lower abdomen region. We don't insert any probes or instruments into the vagina or the rectum. And then what happens is you're taken into the core, or the centre of the machine, which you can see from the image is a very tight tunnel. And for some people that suffer from claustrophobia, and I've recently had an MRI myself because I've got some back pain, it's actually a really quite a frightening experience if you're not prepared for it. The machine tunnel comes right up close to your face. So if you suffer from claustrophobia, it's appropriate in certain circumstances to have some sedative medication to try and help you get you through the test. You should know that the test itself is very loud. There's a very loud jackhammering noise, and so we will often put earplugs or headphones on to try and protect you from that noise. At our institute, we'll routinely administer a little injection called Buscopan, which is a medication designed to try and stop the bowel from moving, because that helps our pictures be easier to read. And in some institutes, they'll administer a contrast agent in the vein, or they may put gel or in the vagina or rectum. That's not something we routinely do because we don't feel it adds very much to the imaging.
So we've touched on this a little bit, I think, and as did the intro, that really the severity of endometriosis and its impact on women has been underestimated in the past, often by the medical profession. And it's been very poorly triaged in terms of what imaging is provided and in terms of clinical assessment, and that has led to limited and poor preoperative assessment. So we sort of come into this concept of deep infiltrating endometriosis, or as people might have thought of it as the surgical words, stage 3 and stage 4. And the words we use in imaging is this deep, or DIE, as you may have heard. And the sort of improved investigation of that has been a real advancement and a change in how we've approached imaging. So this is a scan. You can probably see the date. This was from a paper published sort of, in the 2013, but it's demonstrating how ultrasound used to be reported, which basically sort of just showed comments about, very basic comments about, this is the normal uterus, the normal right ovary, this is was called, an ovulation or hemorrhagic cyst in the left. So essentially this would have been reported as a normal report. My thing that I hate is always seeing no cause for pain found. When there's been no assessment of the uterosacral ligaments, of the pouch, of mobility, of assessment for adhesion. So really, all of the really common places where endometriosis goes hasn't been assessed, but there's still no cause for pain found. So why have patients and surgical teams found this inadequate? So this is the demonstration of someone who has got significant disease in the pouch, with the rectal wall all stuck onto the back of the uterus. Now, in a standard report, that would not be assessed. So, that led to inadequate triage of patients in hospitals. It led to inadequate consent, someone being told their procedure was 45 minutes and it turned into a 4-hour procedure. And, the need for repeated surgeries required to remove disease. So what happened in gynaecology imaging? The Brazilian endometriosis team really pioneered this work in 2009 to show us how we could do imaging better, both in terms of MRI and ultrasound. So these were a couple of papers published then. What's been great is that there's been several Australian teams who have gone over and worked with these guys to improve how we can make these assessments of the pouch and for deep disease. So this is a picture from their paper that they published to show us how to do it better. This is the rectum, and then this is the corresponding ultrasound picture. So this is the normal bowel wall. This is the normal internal part of the rectum, and then there's just this large deposit of endometriosis. And corresponding over here, we can see that the degree of distortion it's creating of the rectum, and then that is stuck onto the back of the uterus. And this kind of endometriosis can affect sort of a significant number of women who have deep disease. It commonly affects the rectum. It's actually very easy to see on ultrasound when you've been trained how to do it. And often women with this condition have very severe pelvic and bowel symptoms. And this requires a certain surgical team to manage it well.
So now we're just going to segue into who should get an MRI. And I think it's important to realise that MRI is a complementary tool to ultrasound. And what we've found is it's best used in a collaborative fashion with the ultrasound imaging. However, there are a few specific indications. In our practice, we largely use MRI for those patients with known or highly suspected deep infiltrating endometriosis. And it's not really a tool for the diagnosis of or evaluation of pelvic pain that doesn't have a specific diagnosis. At our institute, it's particularly useful for surgical planning, especially in those patients with a suspected bowel or bladder involvement, as this helps the gynaecologists plan the type of operation that they're going to perform and whether they need the help of a colorectal surgeon or a urologist at the time of the operation. There is a role for those patients who can't tolerate a transvaginal ultrasound, and MRI is certainly an excellent problem-solving tool. So here we have a case of a lady who had an ultrasound for pelvic pain, and this lesion was seen on the left side of the pelvis, and the question was raised of what it was. Was it an endometrioma? Was it a funny-looking fibroid? Or was it a funny congenital abnormality, which is what it turned out to be? And the nice thing here is that MRI could be quite definitive about the diagnosis and help plan management. However, having said all this, MRI is not for everyone. And what we need to remember is that MRI is a massive magnet and it behaves as such. And so here we have a picture of, thankfully not at my place of work, where someone inadvertently brought a wheelchair into the MRI machine room. And that wheelchair got pulled into the centre of the bore of the MRI within a second of it getting to within the field. And you can see it took about 5 people to remove that. You can't turn the MRI machine off. We're very lucky in that instance that a patient wasn't lying in the machine at the time. So You laugh. So it's important to know from your own perspective that metal in your body is something that you need to tell your doctors about if they're planning to do an MRI. And these are some of the things that you need to let your doctors know about. What does endometriosis look like on MRI? So here we have two images. On the left side, you see what's called a T2 weighted sequence, and on the right side is the specialised sequence looking for endometriosis. And what we can see here is we're chopping the body in half down the middle, and you can see the hips and the spine and the uterus. And on the right side there's a large ovarian endometrioma or chocolate cyst, and there's a cluster of them on the left side. Endometriosis can look like all sorts of things. Here's a different case where the endometriosis is this large plaque-like deposit on the back of the uterus, also called by some gynaecologists as posterior adenomyosis. And then if we look in this patient and come toward the right side, we can see the bowel just here. And as we come across, we see this large bowel lesion. And that's important for the surgeons to know about because that would change the kind of operation that might be planned for. And just to show you that not all endometriosis is barred or obvious like that, here we have a really subtle case of endometriosis involving those uterosacral ligaments that we've seen on the laparoscopic pictures. And this is the kind of disease that if it's read by the wrong person will be missed. This is not easy disease to detect on an MRI, but this is the kind of disease that can be really symptomatic in patients, and it's important to know about.
The cost of a specialist ultrasound varies widely across Australia. So in Melbourne, the cost would be between $280 and $300, and the Medicare rebate is $83.55.
And then by comparison, there is no Medicare rebate for MRI. And the cost around Melbourne varies from $250, which is the place where I work, to up to $550 out in private land, and it can even go upwards if you have contrast as well.
So we're just going to finish off by just going through the model that we use at Mercy in Austin for management of endometriosis, and this has been operating since 2006. So we have a multidisciplinary meeting where we have gynaecologist, an IVF specialist, an ultrasound specialist, which is myself, radiologist, Natalie specialising in MRI, nursing staff and the other relevant surgeons. And it allows for case discussion with regards patients, their history, the imaging's presented and management plans are discussed. And this also allows us as imaging specialists to see surgical findings and then re-review the images and see how we got it right, did we get it wrong, what could we have done better. And it also allows for academic in terms of education and collaboration between specialties to understand things better and opportunities for advancing research in endometriosis.
What we hope we've shown you today is that both the ultrasound and MRI can be useful in the detection and staging of endometriosis. Ultrasound is really the first-line investigation for pelvic pain or suspected endometriosis, and MRI can act as a supportive tool to further confirm and delineate the extent of the disease. We believe that both the ultrasound and MRI needs to be performed by the right people and preferably in a collaborative approach. And in our experience, the multidisciplinary approach has had the most benefit because it provides a forum for clinicians to discuss complex patients, to review complicated imaging and to learn from that process. And it provides an opportunity for different specialty groups to work together in the management of this difficult disease to ensure that patients get the best outcome.